Hi, welcome to this episode of Coding Matters. This is a very shortened version of our focus on rehabilitation, and I'm joined by Dr. Maria Paul, who's the medical lead for rehabilitation services in the Central Adelaide Local Health Network. So Maria, one of the biggest things in rehabilitation that we want to emphasise is the difference from diagnosis-related group activity-based funding, so DRG, versus something that's relatively new to me, ANSNAP funding. What's the difference between ANSNAP and DRG, and why is it so good for rehabilitation?
So ANSNAP stands for Australian National Subacute and Non-Acute Patient Case Mix. This is a more specific case mix than DRG. So it reflects the complexity of the patients much more in terms of rehabilitation. And in order to get an ANSNAP classification, all we need is to enter data onto AROC, and that includes patients' functional independence measure, motor and cognitive scores, their impairment code, age, etc. So this can be really easily done and done contemporaneously as the patient is admitted and we have the first case conference.
Okay, that makes sense to me. So the essential ingredients for accessing ANSNAP data and funding is a little bit different. It starts with the same idea of high quality documentation that fleshes out the reasons why someone has come to rehabilitation, the nature of the deficits that are being focused on, and also the relationship between their management and other comorbidities. But then we need to capture that specific data within the AROC tool, but also the AROC data tool needs to reflect what it's already documented, so that quality documentation supports AROC. And then we have age, we have FIM, motor and cognitive scores. Tell us a bit about FIM scores.
So FIM stands for Functional Independence Measure, and this is the biggest outcome measure we use in rehabilitation. The lowest score anybody can get is 18, where they are fully dependent, and the highest score is 126, where they are fully independent. And our aim in rehabilitation is to get them as close to 126 as we can. Having these scores put in at admission and at discharge is a really important part of rehabilitation. But that alone is not sufficient. We need to enter these scores and everything onto the AROC document. At the same time, we need to have the descriptors in the patient's notes as to what is the diagnosis, what are the comorbidities, what are we treating, and why we are treating. These need to be clearly spelled out in the documents.
So ANSNAP really gives us a more powerful data set to learn from and to really assess our clinical performance as a medical service. But probably most importantly, it enables more accurate reimbursement of funding for the services that we are providing to our patients to maximise their recovery and ongoing quality of life. So here's a very powerful example of a 43-year-old patient who's admitted following a motorbike accident, and they suffered a fracture dislocation of the fourth cervical vertebrae, so a spinal injury with contusion to the spinal cord at the same level, and they're transferred to rehabilitation care after their acute surgical management. So you can see on the top line, this is where we're using DRG-based funding because we haven't got the sufficient data entered through AROC to access the ANSNAP data. And in that group, you can see that we're only accessing about $7,000, which is not at all reflective of the amount of time, expertise and resources that have been invested in this patient's recovery. However, if appropriate data was collected and appropriate documentation done in good quality, we can access ANSNAP funding, and the difference in funding there is closer to $56,500. That's an enormous difference, and just one of many examples where there is a significant uplift that is much more reflective of the high quality service that's being provided for that person's care. This is an example of the AROC tool that we use within our Sunrise electronic medical record. So if you're working with the CALHN or even other networks that are now coming online with EMR, this would be something that you'd be very familiar with. Any tips for entering AROC data, Maria?
The biggest tip is to do it contemporaneously. So as soon as your patient is admitted, you have your first case conference, start entering the data, and as soon as the patient is discharged, make sure that the data is complete, because it's a lot more difficult to try and remember and correct any errors weeks or months down the line.
Well said. In terms of quality documentation, like we've alluded to, here's a framework that you can refer to. So some of the really specific things are about documenting the initial injury or medical condition that has led to the specific impairments and the nature of those impairments, Most patients have multiple that need to be addressed, so writing in detail what they are and how they impact the patient's function. And then linking in through clear terminology like due to or secondary to the comorbidities that would have an influence or require active management whilst they're having their rehabilitation admission. They're the really key points that will help flesh out the complexity through documentation. Here are a few common terms that we might use. Again, if you've seen our other videos, there's a common theme of terms that we use that we then assume the actual diagnosis, but don't actually reflect appropriate diagnostic terminology. So you can see on the left some terms that are probably more like impressions, clinical symptoms, or clinical signs. They cannot be coded. We need to use specific diagnostic terminology, and you can see on the right-hand side a number of examples more specific to the rehabilitation field that can be used to code and add to complexity. So to summarise what we've talked about today, we've talked about very specific data collection, and we've talked about the contrasting difference between DRG, which we use for most of our acute inpatient admissions, versus ANSNAP, which can be used for rehabilitation and some other forms of subacute care as well. And then we've talked about the AROC tool and the specific data, which is informed by high quality documentation in your medical record that will enable us to access that more appropriate funding through ANSNAP. And finally, we've summarised a framework for documenting within rehabilitation admissions and some of the common terminology that we need to be very specific in using diagnostic terms in order to accurately reflect that complexity. Thanks for joining us, Maria.
Thank you.